you so much for having me amongst all of you. So my topic for today is to assess the risk factors for the presence and severity of obstructive sleep apnea, which is basically a sleeping disorder among patients with type 2 diabetes mellitus. This was basically a cross-section study done under ICMR, which is the Indian Council of Medical Research, conducted about 2 years ago, which I had completed during my final year of college and internship. And it was accredited and also given for funding for the same. Just for the sake of introduction, I'm Divij, one of the first year internal medicine residents in a tertiary care hospital in Perth, Australia. Without further ado, we're starting. So this is basically the background, giving you the index of what my presentation is going to break into. So first telling you a bit more about the background, which basically sheds light on the reason to undertake this study and why it was so intriguing to invest. The relationship between obstructive sleep apnea and type 2 diabetes in individuals comparing with their BMIs and individuals who have BMI less than 25, individuals who have BMI more than or equal to 25. And also to assess the risk factors for OSA in type 2 diabetes patients with regards to the HbA1c level, which is long-term control of sugars, and the fasting blood glucose levels. The materiology which was used the study was conducted in Department of Medicine, inpatient and outpatient both at a tertiary care hospital. It was a cross-sectional based hospital study where every patient above 18 years diagnosed with type 2 diabetes mellitus and who consented were undertaken in the study. A sample size of about 164 patients were recruited. So firstly, I did an interview, we're doing an interview session with a semi-structured pre-tested based questionnaire was administered, which basically sought information on the social demographic characteristics of the in terms of their medical history, how long have they been suffering from diabetes, when they were diagnosed with diabetes, any history of alcohol, smoking, and other comorbidities like hypertension, dyslipidemia, chronic liver kidney disease, and if they have or sought treatment for any complications like the nephropathy and the ophthalmopathy or the retinopathy, which also which helps us knowing whether they are at a high risk for OSA. But the poorly controlled diabetic patients who have these complications are at high risk for OSA or at low risk for OSA. The assessments were done with basic measurements: neck, waist circumference, height, and weight of the patient. Glycated hemoglobin, HbA1c was taken previous records, and the most recent one was undertaken, and a fasting blood glucose was taken from everyone who was recruited in the study. Questionnaires, such as Berlin questionnaire and Epworth sleepiness score were administered to assess for the risk factors. Basically, Berlin assesses patients on 3 categories, and they classifies further into patients into high risk obstructive sleep apnea and low risk obstructive sleep apnea based on the categories level they test positive for. And Epworth this questionnaire is basically a scale which scores ranging from 0 to 24, and a score greater than 10 or equal to 10 means that the patient is suffering from excessive daytime sleepiness. And we correlate that with the risk for obstructive sleep apnea using statistical analysis such as p-value. A p-value of less than significant in terms of if the value was found out to be less than 0.05, then basically we went ahead and concluded that that particular risk factor was significantly associated with high risk for obstructive sleep apnea. Moving forward to the results which we observed from the study. So I've tabulated all of them in the form of a tables just for the ease of ourselves. Excuse me a bit. Pardon me. The interviews which sought information on the social demographic characteristics of patients, that is men and women, and further then subjecting them to the age, neck circumference, what was the particular waist circumference, and the neck circumference and the waist circumference are taken in centimeters, and that's the mean value. You can see in men, its range is higher, 38.4 plus minus 3.1. In female, it's about 35.6. And you can see the association when the p-value is less than 0.0001, which means that it is less than 0.0001. 0.05, which means that they are statistically associated. The neck circumference, waist circumference, and the BMI, which are actually associated risk factors for obstructive. Yeah. So going forward, this was a table 2 to basically distributing the patients based on BMI by obstructive sleep apnea risk. So this was about 164 patients taken. 64 were classified as high risk obstructive sleep apnea as per the Berlin questionnaire, and 100 were classified as low risk obstructive sleep apnea. And this we found out whether BMI was a significant association predisposing to high risk OSA in patients with type 2 diabetes mellitus. And the p values highlighted in red, which means that it was statistically associated in basically disposing patients to high risk OSA levels. This was the BMI 11, 21 patients, 43 patients, which the mean average was taken. The ones in brackets are basically the percentage of the total value of the total study population. Then we have the correlation again of obstructive sleep apnea based on fasting blood glucose levels. I've divided into the tables in the form of classifying as per their BMIs, their fasting blood glucose level, the HbA1c, and the social demographic characteristics. We've looked at some social demographic characteristics. We've looked at BMI over here, which was significantly associated. Now we look at fasting blood glucose levels. In this, the p-value was 0.14, which means that which as per our study was not significantly associated with high risk obstructive sleep apnea. Now this is a bit contradicting because studies have proven that obviously fasting blood glucose level, if it's deranged, is obviously associated with worsening diabetes and high risk obstructive sleep apnea. But this is something which was just not observed in our study. With HbA1c level, we again found the same thing, that it was not significantly associated, as the p-value was not less than 0.05. And here they are. Again, there's another contradicting piece of studies we found from the background, because of obviously disarranged HbA1c will lead to poor control of diabetes, and obviously will predispose the patients to obstructive sleep apnea because of the association and the common pathophysiological link between obstructive sleep apnea and type 2 diabetes. But this is something which we just didn't observe or tabulate in our study because of from our statistical analysis. Moving forward, this is as per the score. So ESS is the Epworth Sleepiness Score. And you can see that ESS score, neck circumference and waist circumference, as also previously enumerated, were associated with high risk of obstructive sleep apnea, or statistically associated with high risk of obstructive sleep apnea because of the statistical correlation of p less than 0.05. The diabetes duration was not actually associated in terms of people who are diagnosed 5 years ago, 10 years ago, 15 years ago. That did not actually value much in our study because that was not found to be statistically associated for high risk of obstructive sleep apnea. Moving forward, now this is again another table where we classify those patients, again high risk and low risk OSA levels, into snoring, witnessed apnea, hypertension, or other comorbidities like I've described, dyslipidemia, chronic liver disease, chronic kidney disease, and other things. We found statistical association in all of them, which in a sense means that diabetic patients who are habitual snorers, who witness apnea about 1 to 2 to 3 to 4 times a day, who also have concomitant hypertension and other comorbidities, are statistically associated for high risk of obstructive sleep apnea. All these factors play and predispose the patient to high risk of obstructive sleep apnea in our patients with type 2 diabetes mellitus. Now this is a bar. And from this one, we found out that smoking and alcohol in patients with type 2 diabetes mellitus do not actually predispose to obstructive sleep apnea. Again, a bit contradicting with few studies and also validating a few studies, consistent with a few studies, but that's just from our statistical analysis. We could not find association in terms of poor diabetic control, alcohol, and smoking. That was not significantly associated for high risk of obstructive sleep apnea. This is a pie chart representing patients who are diagnosed with high risk obstructive sleep apnea and low risk respectively, denoted in green and red respectively, as per the Epworth as per the Berlin's questionnaire, which actually categorized the patients into high risk and low risk. It's a whole formulated questionnaire. I've attached in my reading material in my references as well, where we can get the questionnaire and how it is essential to use that as a tool to diagnose patients and to screen patients or screen diabetic patients for obstructive sleep apnea. Now, there are certain limitations of our study. Naturally, no results, no study comes without this limitation. So the first limitation was that obstructive sleep apnea, the gold standard for diagnosis is actually sleep studies, what we call as polysomnography, was not used, obviously because of the invasive nature and challenging nature of the sleep studies, which has to be conducted with a lot of specialists around. So obviously that was not used. Hence we used questionnaires in this. And obviously with questionnaires, it's not 100% yield of telling you whether the patients are of high risk or low risk OSA. So that was one limitation in terms of the questionnaire. Secondly, the HbA1c values of all patients were not reported. These were patients who have not had continuous checkups, who are not adherent, and obviously the latest HbA1c was not reported and was not recorded. Hence, we did not take HbA1c of all the patients, roughly of about 164 patients. Roughly around 90-95 patients had the HbA1c levels measured, which we took into account. So again, that was one of the limitations, that we could not get HbA1c of all the 164 patients. So in a sense, the conclusion of our studies is that obstructive sleep apnea has a high prevalence in type 2 diabetes mellitus patients. The significant risk factors in type 2 diabetes which predispose to high risk obstructive sleep apnea are the following, which I have underlined here: the BMI, the neck waist circumference, hypertension, presence of other comorbidities like dyslipidemia, chronic liver kidney diseases, frequency of snoring, whether they are habitual smokers or whether they're habitual snorers or simple snorers, and excessive daytime sleepiness from the Epworth questionnaires were proven to be high risk. And all of them, the p-value was less than 0.05. Fasting blood glucose and HbA1c, interestingly and paradoxically, were not associated to post type 2 diabetes patients at high risk of obstructive sleep apnea. But again, as I mentioned before, this is a bit contradicting, but this is just what we observed from a statistical analysis. Alcohol and smoking were another two factors from the history which were not associated in determining high risk of obstructive sleep apnea. Now, key home pearls are certain things which we as doctors have to take back home, and also some patients which have to take back home out of every studies we do and out of all our consultations. It's not just a learning practice for the patient or the doctor, but it's actually dual folded. It should be a bimodal learning process for both the patients and the doctors. So for the patients, the going back learning process was that a lot of patients who were actually deemed to be high risk obstructive sleep apnea did not know anything about obstructive sleep apnea, about what it is and how it works. It was absolutely nothing, and unwary about the consequences of health that can lead to fatigability. You need to have a CPAP machine at night. They were patients with type 2 diabetes mellitus were completely unaware and oblivious to this condition. For the doctors, it actually prompts the need to do sleep evaluation and rigorous screening for obstructive sleep apnea, if not using sleep studies, but just basic questionnaires and a comprehensive clinical history and examination to be vigilant about obstructive sleep apnea, which is actually quite prevalent in patients with type 2 diabetes mellitus. We found out before about 18% primary care to up to 50-60% in higher places. And again, it depends from country to country and the recent studies as well. Touching upon that, as that being said, clinicians and mental health, and all the health practitioners must be observant for the signs and symptoms of obstructive sleep apnea and type 2 diabetes mellitus patients. So type 2 diabetes mellitus patients coming with hypersomnolence, fatigability, tiring, weight gain. It's prudent for us to think that, okay, if it's whether it is diabetes or whether it is something else which is adding on, whether it is diabetes leading to poor diabetes leading to increase in weight and fatigability, or whether this is something else. So at that point, we have to actually rule out things and go into this narrow spectrum obstructive sleep apnea to actually find out whether they have that component of OSA in them, which just basically narrows down to asking if they have sleep troubles, what kind of sleep troubles, anyone else has observed it, if anyone else has observed any snoring, so we can actually unravel the mystery of why and what's happening. And just in terms of finding the prevalence of obstructive sleep apnea in patients with type 2 diabetes mellitus. These are my references taken, mostly taken from Journal of Clinical Sleep Medicine and from the basic journals, also some from Mayo Clinic about the studies done on obstructive sleep apnea. So in the end, it all narrows down to this, that we should look for additive risk factors and look for obstructive sleep apnea signs, especially in patients with poorly controlled type 2 diabetes mellitus patients and patients who have other risk factors and patients who have concomitant comorbidities as well. It's very prudent to look for that. So that's basically forms the gist of my study. Thank you so much for this opportunity. I'd like to forward the floor to the moderator. Thank you so much.